Welcome to one more episode of the cataract class. This video has a slight recording delay and the incisions has already been constructed. The incisions, the main port is at 170 degree, the side port is at 280, and there is one corneal relaxation incision CRI at 7 degrees. This is guided by the varion. So as you can see in this patient, the pupil is not well dilated. This is a poorly dilating patient. So this is a case of an diabetic cataract in which the patient was having diabetic edema, for which she has received 3 doses of anti-VEGF prior to the surgery, and the patient is taken up for surgery after the macula was dry. But we will still give an intravitreal and IVTA injection just to make sure that there is no more DME post cataract surgery due to inflammation. So we have put in the trifant blue dye, stained the anterior capsule, and now we are going with the capsular access. Here we have to be very careful as the pupil is little smaller than the usual. It is around 7 to 8 mm in size, the pupil dilatation. So we have to be very, very careful with all the techniques we do, and will take little more time than a regular phacoemulsification case. So we wash out the viscoelastic and now hydrodissect and hydrodelineate the nucleus. I prefer in cases of little hard cataract to do a multi-quadrant hydrodissection. This gives a better movability of the nucleus and frees up the epinucleus and the cortex. Now we will rotate the nucleus, and yes, it is having a good rotation. This is a basic step before starting the phacoemulsification. Otherwise, it would be troublesome to do the phaco once you are inside. We are clearing of the superficial epinucleus and the cortex. Now making a small trench and attempting a direct chop, and yes, we have completed a full chop. Rotating the heminucleus, and then we are emulsifying the loose epinucleus sheets that are coming in the view, and then chopping up the pieces. Now some cataract surgeons prefer to chop up the entire nucleus and then start emulsifying them, and while some prefer to crack the pieces and emulsify them piece by piece, and while proceeding with the other pieces subsequently chopping and emulsifying. This is by virtue of my training. I emulsify pieces, small pieces, and chop small pieces and start emulsifying them. This gives me a little space to work and is much more comfortable. You can follow what you are doing in your training. You can chop all the pieces up, make it into small pieces, and then start emulsifying, or you can do this as you feel comfortable with. So going along with the last piece, be very careful. See the chopper. The chopper is now in the safety position. It is a little outside at the side port, just to bring the pieces in. And as it is a sharp instrument, you should make sure that it is not placed directly facing the posterior capsule in this penultimate state of the stages of the phacoemulsification. If the capsule comes up, or if there is a loss of the surge, it might hit the capsule and cause an PCR. So be very careful with the chopper when you are emulsifying the last pieces, and also during the epinucleus phase. Now we will go in with the coaxial and start to take out the cortex. Yeah. We have cleared up the cortex from one hemisphere. Now we also have this CRI port which we had made, and we can access this to the coaxial to clear up the cortex from this side more safely. If we are not having the CRI, then we can only use the main port and sometimes the side port to clear up the cortex. So once the cortex has been cleared up, we will polish the nucleus, polish the capsule. Now fill in the bag and the anterior chamber with the viscoelastic. Now during lens implantation, most important thing is to fill in the bag with the viscoelastic. You will note that the bag inflates with the viscoelastic. This gives space for the IL to be implanted and IL to be rotated. During implantation, be little slow. Do not give any jerky movements to the IOL. It might come out in a jerk and might injure the capsule. So the leading haptic is in. Now the lagging haptic is being dialed in inside the capsular bag. Now ensuring centration. Yeah, it is properly centered. Now the visco would be washed out from the anterior chamber and from beneath the IOL. You can just nudge the IOL to let out the viscoelastic from underneath, and also sometimes give a jet of fluid, and the viscoelastic from underneath comes out. This is the intracameral moxifloxacin being injected in. Now we will proceed with the IVTA injection. This is 3.5 mm we have measured with the caliper. Now see how the needle goes in. This is a 30 gauge needle. We go in through the 3.5 millimeter mark we have made. We point the needle towards the optic disc, inject, and slowly come out, rotating the bud, not to allow vitreous to prolapse.